thank you for the introduction. So actually I'm going to present just quickly 4 cases for the paravalvular leaks. Hopefully I'll be done in 15 minutes with this. So paravalvular leak actually is not an uncommon disease. It occurs in 7 to 17% of valves, and usually they present either with heart failure or hemolysis. They're usually difficult to treat and they're underestimated. Usually when you have a mechanical valve and you do a TTE, sometimes there's shadowing and you don't see the mitral regurgitation, and you have to suspect it with high velocity and the initial velocity. So usually the risk factors for VBL are annular calcification, tissue friability, endocarditis, inflammation, rheumatic heart disease, people on steroid therapy, and poor implantation technique. So usually the indication for treatment is heart failure or severe hemolysis. You have an LDH more than 1,000 usually, and the treatment either repeat surgery or percutaneous closure. There's a new paper in JACC Intervention that were published a couple months ago comparing surgery, repeat surgery versus transcatheter. And one paper, it showed no difference in mortality. And the second paper showed actually surgical reduction in death and readmission if you repeat surgery, but you have an increase in early mortality and morbidity compared to percutaneous closure. This is now there's also a consensus document about how to grade them and how to treat them, and a very nice paper in JACC. From the Mayo experience, about 206 patients who had paravalvular leak, around 50% had replacement and 50% had repair. And the most common location for the paravalvular leak was either the aortic mitral curtain in 40% and medial leaks in 26%. So if you decide to do paravalvular reclosure percutaneously, you have to have a lot of anatomic consideration. The majority of these people underwent multiple surgery. They have cardiomegaly. It can happen at any point, anywhere in the prostatic valve. It can happen usually in multivalvular. A lot of these have rheumatic heart disease. They have a mechanical aortic, mechanical mitral, which makes your planning very important. So usually what does affect your technical success in paravalvular leak is the inability to access the PVL. If you have a mechanical valve, it's more difficult. If you have a thrombosed IVC filter, you cannot go transeptal. Medial location of the leak is always very difficult to reach, and inability to cross if you have a serpentinous tract or a lot of calcification. So usually the favorable are if you have a discrete leak or lateral leak. If you have a medial or a serpentinous leak, usually they're unfavorable, and you have to explain to the patient that it might be more difficult to close them. And it's very important to differentiate if you're doing a paravalvular leak for bioprosthesis or mechanical MVR, because when you have a mechanical valve, you have a higher risk of interfering with the leaflet. So you have to make sure that you check for leaflet interference before releasing the device. And usually the goal of closure, if you have heart failure, is to close the leak completely or to decrease mitral regurgitation. And for hemolysis, try to abolish. But you have to explain also to the patient that hemolysis actually might not improve in 1/3 of patients. And this is very important to say it up front, because a lot of the time hemolysis will not improve. And usually we have 2 types of paravalvular leak, the aortic and the mitral. Usually we approach the aortic by retrograde through the femoral artery. And the mitral paravalvular leak, there's 3 ways of doing it: transapical, transeptal, and transaortic. And I'll present a case for each. Usually, you need to understand the devices you're using. If you don't understand the devices, don't go for a paravalvular leak, because you have multitude of devices and each leak needs a different device. On the left, you have the PLD devices from Occlutech that are new. They're the only one approved for real paravalvular. The rectangular with the good waist. You have the St. Jude AVP family. You have the AVP2, which is mostly round, and it's done for round defect. You have the AVP3, which is oblong for oval defect. The AVP4 is good for post-TAVR paravalvular leak. And sometimes you have to use the AD02, AD01 you use for duct to close paravalvular leak. So this is case number 1, aortic paravalvular leak. You can tell that you have severe PVL. Patient came in with heart failure. It was just below the LCC, below the left coronary cusp, so below the left main. So there is a couple of ways of closing it. You direct close with the catheter and cross with the Terumo wire and deploy the device, or you put a safety wire in case you think you have to put different 2 or 3 devices so you don't lose access to the leak. And this is how we did the case. We took an aortogram. You can see the leak. You cross with the amplats and a Terumo wire. Then you put your delivery sheet inside the LV. Then you put telescoping with the long multi-purpose and a 6 French MP guide, and here we use a 10 millimeter AVP2, and then you pull your devices where you have one disc in the LV size, and you put the lobe in the middle, and then you put the other disc in the aortic side. Here it's very important to do a tuck test to make sure that you don't have the device pull back into the aorta. And what's very important, especially when you have a defect in the left coronary cusp, is to inject the left main, make sure you did not interfere with the left main before releasing. And here, after checking that the left main is fine, we released. We don't have any more leak around the left coronary cusp, we just have the washing jet of the valve. Usually aortic paravalvular leak are easier than mitral, and usually one plug, if you size it well, is enough. And this was the result at the end in 3D. We don't have any more leak, and you can see the device below the left coronary cusp. So I'm going to shift gear to the most difficult stuff, which is the mitral PVL. I'm going to show a case first of transaortic, then transseptal, then transapical. So it's very important when you're doing a mitral to understand the anatomy. What the echocardiographer shows you is a surgeon view. You have the mitral valve on the left and the aortic valve anteriorly. The interventional view, when you're on fluoro, you see it the other way around. You have the mitral valve on the right and the aortic valve anteriorly. So first thing is you need to have a very good echocardiography before going to the cases. And according to the view, you can decide. In A, you can see you're on 60, 90 degrees in the TEE. You're next to the appendage. This is an anterolateral leak. And in position B, this is the 120 view. You have your aortic valve, and posteriorly, you can see you have a posterior leak. In C, you see it's next to the LVOT and the TE 120 view. This is an anterior leak. And in D, it's at 0 degree next to the septum. This is a medial leak. So it's very important before embarking this procedure to have a very good TE and a very good images and understanding where the leak is. And it's very important that you understand your fluoroscopic markers. So usually when I'm doing mitral PVL, I go in two views. I go RAO 30 and I go LAO caudal. In RAO 30, I know my anterior and posterior position. This is in panel B. So I know if I want to target posteriorly how my catheter is going to look. And in C, if I want to look between medial, anterior, lateral, and posterior, where I want to go. So you go LAO caudal, you have a round shape of the valve, and then you can decide where you want to go. And 3D-TE is crucial to size and to see if this is a circular, oblong, serpentinous track. Do I need multiple plugs or one plug will suffice? So this is a case of a mitral PVL with a posterior approach, with a posterior leak. You can see the aortic valve on the 120 and it's on the posterior. On 3D-TE, it showed us that it was circular and around 7 millimeter. So what we did in a step-by-step approach for retroaortic, so for posterior mitral PVL, retroaortic is very good. You take a 5 French GR4 catheter across the aortic valve, and then you cross the leak with a Terumo wire. Then you put a catheter in your LA, change to a stiff wire, deliver your delivery sheet, which is usually a shuttle sheet. The shuttle sheet is very hydrophilic, and it crosses very well. You usually put a safety wire so you don't lose access, and then you decide which PVL device you want. In this case, it was a 7 to 8 millimeter circular, so we decided to go with the AVP2 12 millimeter. And this is how you do. You go retroaortic. I know from my RAO 30 where posterior is going to be. I introduce my catheter and cross easily into the left atrium. And on the second screen, I also labeled anterior posterior. I know I'm outside of the valve. I make sure I'm not intravalvular. And then here I'm going to show this, and here I already deployed the left atrial disc, and then here I'm deploying my LV disc. And this is the result after releasing with no valve interference. And if you look, that's the echo result compared before and after. And on the right panel, you can see in 3D your leak sitting nicely without any valve interference. So I'm going to move to an apical approach. So usually apical approach are very good for, transapically are very good for medial leaks because they're very close to the septum and they're very difficult to cross from the transseptal approach. So this is a patient who had 3 operations before and could not be repeated. And by 3D TE, we could tell this is an oval defect. So here I'm not going to use an AVP2. I'm either going to use an Occlutech device or an AVP3 device that is oval. And this is the leak medial next to the septum from TE. So for transapical approach, it's very important to have very good planning. So you have to locate the apex with the TTE and make sure you deflate the lung before puncturing. Usually use a micropuncture needle, and you puncture through the skin with a deflated lung into the left ventricle. Then you introduce your sheet, cross the defect with a wire, and then deploy in a regular manner. And then you want to close the apex also with a plug. So this is how the setup. So I located my apex with the TTE. I mark it with a marker, and this is where I want to puncture. And on the right panel, you can see I have a contrast needle. I go in with my needle through the apex until I see blood coming back. And this is a percutaneous way. This is not surgical. We don't have any cut down. We don't have any surgeon in the room. And the way we do it, this is on the left panel. I have already put a 6 French sheet in the apex into the LV, and I have a Terumo wire and a GR4 catheter, and I'm trying to locate the leak while having 3D TEE to locate the apex. And you can see I crossed here, and then I have my GR4 catheter now in the left atrium. And on the right panel, you can tell that I have my device here. I can scroll here. In the right position, I'm not intravalvular. I'm outside of the valve here with the red spot. Okay, so here we deployed the device, excellent result. We make sure there is no valve interference. On the right side, you can look, this is an Occlutech device, how it's covering the defect. This is a rectangular shaped device. And this was the end result with perfect result and no interference with the valve. The most important is how to close the apex. And the same way we close the apex, we close it percutaneously. Here I have my 6 French sheet with a 8mm AVP2. I make sure I have the left disc on the endocardium, the lobe of the disc in the myocardium, and then I deploy the other disc in the epicardium. And you can see it's moving with the apex. And usually this will be enough to close. And this you can see some contrast going into the pericardium, but usually it seals by itself because there's a lot of adhesions. And this is the CT result after. You can see the defect, the plug sitting, half of it in the endocardium, myocardium, and outside in the epicardium. And this is usually, it sits well, it doesn't get infected, and the patient was discharged a day after. The last case is another one with heart failure, 2 prior operation. And this time, this is an anterolateral leak. We can see the appendage on the 60 screen, on the 60 TAE view, and usually the anterolateral are easier to get from a transeptal approach. So usually we want to stick posteriorly and in the mid-septum. You want to get a deflectable sheath, an Achilles sheath. I don't know if you know it, I'll talk about it, but you can span the left atrium anteriorly, posteriorly, medially, and laterally to be able to cross. And usually when you're doing from the transeptal, it's better to externalize your wire into the common femoral artery to create an AV rail. And the AV rail is done to increase your support to be able to cross with your sheath. So this is the Achilles sheet I'm talking about. This is a sheet that you can deflect in every plane you want, and you can access any leak and any position. The EP people like it to do their AF ablation. And this is the case where I crossed transeptally. I don't have any markers in my mitral valve, so I relied on Dr. Gharzuddin 3D TE skills and to guide me in the right position. I have a multi-purpose. I cross with my Terumo wire, and the wire is going through the aortic valve outside of the body. And here I got my Terumo wire into the abdominal aorta. I snared it. And now I created a rail where I have a wire coming from the right common femoral vein and out from the left common femoral artery. So I can deploy as many plugs as I want. And here, if you can see, I introduced my sheet. And on the right side, I had deployed an AVP2 14 millimeter with good compression. And this is the result with 3D TEE. And you can see on the right side of the screen, you have a very nice closure with a nice umbrella. And this is another view, a 3D TE view of the plug, and this is with color. with some minimal residual leak. Okay, so in conclusion, PVL leaks are common, percutaneous closure is possible, they can be very difficult and tedious, and patient expectation is key, especially regarding hemolysis. I want to acknowledge Dr. Ghazal, my co-operator on all these cases, and Dr. Walid Khairzeddin for his superb 3D TE skills to guide me through this procedure. Thank you.